In 30 years of practicing cardiology, I have looked at thousands of hearts. Not scans, not charts, actual hearts. I have been inside chests when everything was going wrong, and inside chests where the damage had already been done long before the patient ever reached my table. And the thing that keeps me awake, the thing I cannot stop thinking about after 3 decades in this field, is how often the damage was not from the disease itself. It was from the treatment. Pills prescribed by careful, competent doctors. Pills the patients took faithfully every single morning because they trusted the system. I am Dr. Raymond Osei, interventional cardiologist, 30 years reading the damage before it becomes irreversible. And today, I want to tell you about 5 medications that are sitting in medicine cabinets across America right now, being taken by people over 60 who have no idea what those pills are quietly doing on the inside. This is not a video telling you to throw out your prescriptions. It is a video about the half of the conversation that almost never happens in a standard doctor's visit. The half that could change everything. Here is what changes after 60 that your doctor may never have time to explain properly. Your kidneys slow down. Your liver processes compounds at a fraction of the rate it did at 40. The pathways that break down medications, absorb nutrients, and regulate cellular chemistry all start operating at a reduced capacity. The drugs your body could handle efficiently at 50 become a different calculation at 65. And the average American in that age bracket is not taking one drug. They are taking 4 or 5. Some take 8 or more. Each one was approved in isolation. Each one was tested on its own. What no trial has ever fully accounted for is what happens when 3 or 4 of them run simultaneously inside a body that is already working harder than it used to. That gap right there is where the real danger lives, and it rarely comes up in a 7-minute appointment. I want to tell you about a patient I will call Walter, 71 years old, former high school football coach, the kind of man who never missed a checkup, never ignored a prescription, never skipped a dose. Walter did everything the medical system asked of him. He walked every morning. He switched to a heart-healthy diet after his first cardiac event at 68. He had every reason to believe he was winning. By the time he came to see me 2 years after that event, he was a different man. The fatigue was not the normal tired of aging. This was a heaviness that sat on him like a second body. He could not think clearly. His legs cramped in the middle of the night so severely, his wife would wake up and find him on the floor trying to stretch them out. He had been to 3 different specialists. Each one told him some version of the same thing. Walter, you are 71. This is what 71 feels like. I reviewed his medication list on our first meeting. All of it. Every pill, every dose, the timing of each one. I saw what was happening inside 20 minutes. Not one problem. 4, running simultaneously, silently, for 2 years. We will come back to Walter because his story does not end where those other appointments left it. Now, the 5 medications. Let us start with the one that sits at the very center of modern cardiology. Medication 1, statins. Atorvastatin, rosuvastatin, simvastatin. The names vary, the mechanism is the same. If you are over 65 with any history of cardiovascular disease, there is roughly a 1 in 3 chance you are taking one right now. And I want to be completely clear before I say anything else. For patients with established heart disease, statins save lives. The evidence is overwhelming and consistent. I have prescribed them thousands of times, and I stand behind that decision. But there is a consequence to statin use that has been documented in peer-reviewed research for over 2 decades, and that almost never makes it into the patient conversation. Statins block what is called the mevalonate pathway in the liver. That pathway does 2 jobs. It produces cholesterol, which is why statins work, but it also produces something called coenzyme Q10, CoQ10, and that second job is where the problem begins. CoQ10 is essentially the fuel source for cellular energy production. Every cell in your body depends on it, but the heart depends on it more than any other organ because the heart never stops. It is running 24 hours a day, every day of your life, and it needs a constant supply of CoQ10 to do that efficiently. Multiple published studies, including a meta-analysis replicated across different research groups, have shown that statins reduce circulating CoQ10 levels by 30 to 50%. 30 to 50 in the organ that needs it most. What does that deficiency actually feel like in a real human being? Fatigue that does not respond to sleep, muscle weakness that doctors are quick to attribute to aging, mental fog that creeps in so gradually it is hard to pinpoint when it started. And in a measurable subset of patients, a genuine, detectable reduction in cardiac output. The heart running below its functional capacity, while the patient takes a pill designed to protect it. Here is the part that should give you pause. CoQ10 testing is not part of the standard protocol. It is not in the guidelines. Some insurers will not cover it. CoQ10 is available over the counter, costs almost nothing, and has no pharmaceutical patent attached to it. There is no financial mechanism to push it into standard care. The result is that millions of people on statins are walking around CoQ10 depleted, and no one is measuring it. The question to write down before your next appointment is not, should I stop my statin? It is this, should I be supplementing CoQ10 alongside it? The Q-Symbio trial showed meaningful improvement in heart failure patients who supplemented. 100 to 200 milligrams daily is the documented therapeutic range. That is the conversation to have. Medication 2, NSAIDs, ibuprofen, naproxen, diclofenac. These do not look like heart medications. They are sold over the counter. They sit next to the vitamins at the pharmacy. Most people over 60 use them routinely for joint pain, back pain, the physical wear that accumulates over a lifetime of movement. The assumption is harmless. These reduce inflammation. Inflammation is bad for the heart, so at worst, they are neutral. That assumption is exactly wrong. NSAIDs work by blocking COX enzymes. The problem is that one of those enzymes, COX2, produces something called prostacyclin. Prostacyclin is your blood vessel's primary defense system. It keeps the walls of your arteries flexible. It prevents the dangerous clotting events that cause strokes and heart attacks. Block COX2, and you remove that protection. Simultaneously, at the same time your pain is improving, your vascular defense is going offline. But it does not stop there. Regular NSAID use raises blood pressure by an average of 3 to 5 millimeters of mercury. 3 to 5 points sounds modest until you understand what it means after 60, when arterial walls are already less elastic than they were at 40, when that chronic pressure increase accumulates not over a week, but over months and years. The FDA placed a black box warning, the most serious warning category that exists, on NSAIDs in 2015, not only for gastrointestinal bleeding, but specifically for heart attack and stroke risk. That warning is on the label right now. Walter had been taking ibuprofen daily for 2 years for chronic knee pain. His primary care physician knew. Nobody flagged the cardiac implications. For chronic joint pain, topical NSAID formulations like diclofenac gel deliver comparable anti-inflammatory effect with roughly 90% less systemic absorption. For the background inflammatory load that drives cardiovascular risk over time, 2 to 3 grams of omega-3, EPA, and DHA daily has clinical evidence that most people would find remarkable. The Reduce It trial showed a 25% reduction in major cardiovascular events with high-dose omega-3. Curcumin with piperine has a growing body of evidence for chronic inflammation that does not carry the vascular downside. None of this means you should discontinue a prescribed anti-inflammatory without your physician. It means the alternatives deserve a conversation. Medication 3, proton pump inhibitors. Omeprazole, pantoprazole, lansoprazole. Roughly 15% of the entire American adult population takes one, many for years, some for decades. They were designed for short-term use in most cases. They became permanent. Here is why a cardiologist cares about a heartburn medication. Your stomach acid is not the enemy it has been marketed as. It is a critical biological gatekeeper. You need it to absorb vitamin B12. Long-term suppression of stomach acid does not reduce B12 absorption partially. It blocks it almost entirely. And here is what B12 does that connects directly to your heart. B12 is essential for metabolizing homocysteine. Homocysteine is an amino acid that, when it accumulates, directly damages the walls of your arteries. Elevated homocysteine is an independent cardiovascular risk factor, comparable in some studies to elevated cholesterol, and it is almost never included in a standard workup. A 2013 study published in the journal Gut found long-term PPI users carrying B12 levels 30% lower than non-users. In a population already absorbing less B12 with age, because after 60, your body produces less intrinsic factor, the substance required for B12 uptake, drug-induced deficiency stacked on top of an age-related one. What does it feel like? The same things aging is blamed for. Fatigue, memory problems, a gradual tingling in the hands and feet that arrives so slowly most people cannot remember when it started. In severe, prolonged cases, neurological damage that does not reverse. From a heartburn pill. PPIs create a second deficiency that connects even more directly to cardiac function, magnesium. Your body uses magnesium in over 300 enzymatic processes. For the heart specifically, magnesium regulates electrical signaling. It is the compound that keeps your heartbeat steady and rhythmic. Deplete it, and you get arrhythmia. You get cramps at 3 in the morning that come from nowhere and wake your spouse. Walter's B12 came back critically low at his first full workup with me. His magnesium sat technically within the normal reference range, but at the very bottom of it. Technically fine, functionally compromised. Nobody had acted because the number was inside the boundaries. If you take a long-term PPI, ask for B12 and magnesium levels at your next appointment. For B12 replacement, methylcobalamin in sublingual form, dissolved under the tongue, bypasses the absorption problem entirely. No stomach acid required. For magnesium, the chelated form, specifically magnesium glycinate, absorbs at a dramatically higher rate than the magnesium oxide found in most cheap drugstore supplements. And do not stop a PPI abruptly. There is a documented rebound effect where acid production surges harder than before, you feel worse than when you started, and you end up back on the drug. Taper gradually with your doctor. Statin depleting CoQ10. NSAIDs removing vascular protection. PPIs blocking B12 and magnesium. Walter was dealing with all three of those simultaneously for 2 years. Each specialist he visited saw their portion of the picture. Not one of them saw the combination. 2 more medications. And these are the ones where the conversation inside my own profession has been the most uncomfortable. Because medication 4 involves a drug that prevents life-threatening clots while quietly doing something I have watched unfold on operating tables for decades. And medication 5 involves a recommendation I personally made to patients for 15 years before the data forced me to stop. Medication 4, warfarin. In clinical use since the 1950s, still one of the most prescribed anticoagulants for adults over 65, managing atrial fibrillation, deep vein thrombosis, or mechanical heart valves. Warfarin prevents dangerous clots. It prevents strokes in AFib patients. That is real, documented, life-saving benefit that I am not dismissing. But there is a mechanism of warfarin that the 7-minute appointment almost never covers. Warfarin works by blocking vitamin K activity in the body. It does this to prevent clotting because vitamin K is involved in the clotting cascade. But vitamin K has 2 forms, and warfarin cannot distinguish between them. Vitamin K1 manages clotting. Vitamin K2 does something entirely different. K2 activates a protein called matrix GLA protein, whose entire function is to prevent calcium from depositing inside arterial walls and redirect it toward bone instead. Block K2 and you remove that mechanism. Calcium drifts. Over months, over years, it begins depositing in the very vessels you are trying to protect. Arteries lose their flexibility. They harden. They calcify. A 2019 study in the Journal of the American Heart Association found that long-term warfarin users showed significantly accelerated coronary artery calcification compared to patients on newer anticoagulant medications. Patients whose physicians were actively trying to protect their cardiovascular health were simultaneously experiencing faster arterial calcification than patients on drugs without that K2 interference. As a surgeon, I have seen what heavily calcified coronary arteries look like firsthand. It changes the surgical complexity. It changes recovery. It changes long-term outcomes. Does this mean warfarin patients should stop their medication? No. Untreated atrial fibrillation carries roughly a 5% annual stroke risk. That is not a number to dismiss. But there are two questions worth bringing to your physician. First, given that newer anticoagulant options exist today, specifically medications like apixaban and rivaroxaban that do not carry the same K2 interference, is warfarin still the most appropriate choice for my situation? Second, has anyone measured my coronary artery calcium score? A simple low-radiation CT scan that can be done in a single appointment gives you a precise, objective picture of what is happening inside your arteries right now. One of the most clinically useful and consistently underutilized tools in cardiovascular medicine. One scan, one number. It changes treatment decisions more than most tests. Medication 5, calcium supplements. This is the hardest one to discuss, not because the pharmacology is complicated, because I gave this recommendation myself, routinely, confidently, for 15 years, to women over 60 with early bone density concerns. 1,200 milligrams daily, take it with food. I said that to patients who trusted me. It felt like basic preventive medicine. It felt like common sense. In 2010, a meta-analysis published in the British Medical Journal stopped me cold when I first read it. 15 randomized controlled trials, nearly 12,000 patients. The finding was this: calcium supplementation without accompanying K2 and vitamin D3 was associated with a 30% increase in cardiovascular event risk. 30%. In people taking a pill they believed was protecting them. Here is why. When you eat calcium through food, it enters the bloodstream gradually in amounts your body can direct and manage. When you take a calcium supplement, it floods the bloodstream all at once in a concentrated surge. The body cannot process that volume efficiently, and one of the places excess calcium ends up is arterial walls. The same calcification problem we discussed with warfarin, but driven not by a drug blocking a protective mechanism, driven by the supplement itself. The calcium paradox. You take a pill to protect your bones. Under the wrong conditions, it hardens your arteries instead. Why have guidelines not fully shifted in response to data published 15 years ago? Reversing a recommendation that went to tens of millions of patients for 2 decades is institutionally complicated. There are liability questions. There are industries built around calcium sales. The easier institutional response has been a quiet footnote rather than a direct public acknowledgement. When I read that BMJ meta-analysis and genuinely sat with what it meant, I thought about every patient I had said those words to. Every woman taking her calcium every morning because I told her to. I could not have acted on data that did not exist yet. But I could act on it going forward. And that is why this is in this video. If you are taking calcium supplements, do not stop abruptly, especially if you have documented bone density loss. But bring one question to your physician. Should I be taking K2 and D3 alongside my calcium? The evidence-based answer for most patients is yes. K2 as MK7 at 100 micrograms daily activates the proteins that direct calcium to bone rather than arteries. Vitamin D3 at a minimum of 2,000 IU daily, with dosage calibrated to blood levels for many patients. And wherever possible, the research consistently supports dietary calcium as the primary source. Dairy, leafy greens, small fish eaten with their bones, with supplementation filling gaps rather than carrying the full load. I have spent most of this video on what medications take away. Let me spend the last few minutes on what genuine cardiovascular support actually looks like after 60, because most of it is not complicated and very little of it requires a prescription. Omega-3 fatty acids at 2 to 3 grams of EPA and DHA daily reduce triglycerides, lower systemic inflammation, and help maintain arterial wall flexibility. The clinical evidence on this is stronger than most people realize. Magnesium glycinate at 400 milligrams daily supports heart rhythm regulation, blood pressure, and sleep quality. After 60, dietary intake drops while the body's demand stays constant. Curcumin with piperine has genuine research behind it for the chronic, low-grade inflammation that drives cardiovascular risk over years. Nattokinase, derived from fermented soybeans, has shown real promise for healthy blood flow. Taurine supports cardiac muscle function. Aged garlic extract has meaningful data on blood pressure and arterial flexibility. Both carry long safety records. None of these are substitutes for necessary medication. They represent what the body needs to operate at its capacity, what gets quietly crowded out, and what can be addressed without a prescription. Here is the one thing I want you to do before your next medical appointment. Write down every medication and every supplement you take, every dose, every timing. Then write 3 words at the top of that page. What am I losing? Every drug has a trade. Statins reduce cholesterol and reduce CoQ10. PP is suppress acid and suppress B12 and magnesium. Warfarin prevents clots and accelerates arterial calcification. Calcium supplements support bone density and under the wrong conditions contribute to arterial calcification. None of these trade-offs automatically mean the medication is wrong for you. They mean the conversation is incomplete without them. And you deserve the complete conversation every time. Walter came back to see me 6 months after we rebuilt his care plan from the ground up. 40 minutes, not 7. Every drug, every dose, every interaction, every nutrient being depleted. CoQ10 at 200 milligrams daily. Sublingual methylcobalamin started immediately for his critically low B12. Chelated magnesium added. Daily oral ibuprofen switched to topical diclofenac gel. Same anti-inflammatory effect, 90% less systemic exposure. A gradual PPI taper coordinated with his GPK2 and D3, added alongside his existing calcium. Nothing dramatic, no new surgery, no experimental treatment. We simply stopped depleting the compounds his heart required to function and replaced them. 6 months later, Walter called me. He said he felt like himself again. The exhaustion that had followed him for 2 years was gone. The night cramps stopped within the first month. His cardiac follow-up showed measurable objective improvement in heart function. His GP called me genuinely confused by the improvement trajectory. Nothing changed in Walter's situation, except that the full picture was finally being addressed. That is the thing that still surprises me after 30 years. Not the complexity of what went wrong, the simplicity of what helped. Targeted supplementation, 1 medication swap. A 40-minute conversation that 3 prior appointments had not made room for. The medications on this list are not the villains. The doctors who prescribe them are not negligent. The problem is a system that has time and financial incentive to write the prescription and almost no mechanism to ask, what is this combination quietly doing 2 years from now? You cannot fix that system today, but you can walk into your next appointment with a complete list and 3 words written at the top. And sometimes, as Walter will tell you, that is enough. If this conversation was useful to you, share it with someone managing multiple medications, a parent, a partner, a friend who has been told their exhaustion is just part of getting older. It may not be. Everything covered here is grounded in published research and 3 decades of clinical practice. Your situation is individual. Bring these questions to your physician before making any changes. This is meant to be the beginning of a better conversation, not a substitute for one. Take care of your heart. It has never once taken a day off for you.